So before we move to freelancer session, that is the most important session of the Tascon. There is a change. Dr. Anurag Agrawal, who is going to speak on percutaneous vertebroplasty, will take the presentation first because he has to leave. So I invite Dr. Anurag Agrawal for presentation on percutaneous vertebroplasty.
As we all know that pain medicine is also a kid of anesthesiology, which is coming up in a big way. We are trying it as a super specialty of anesthesiology. Let's hope that we will someday be able to do this. And my talk is based on the pain medicine, vertebroplasty, that is also known as cement augmentation by the percutaneous way. So good morning once again. This is me. I am working at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, as a pain spine physician, also as a professor in the Department of Anesthesiology. We have recently formed a society that is known as Endoscopic Spine and Interventional Pain Society of India, that is ESIPS. This is dedicated for the endoscopy, percutaneous endoscopy procedures in the pain medicine. So to start with the cementoplasty, this is the MIPSI. MIPSI is the umbrella term for all the interventions which we do in the pain medicine, that is minimally invasive pain and spine interventions. They are no more known as block or injection because names do matter. The purpose is to fix a fractured bone, that is usually the vertebra, but it can be other bones also, like the sacrum, like the other places. The history is quite not that long. Only in 1984 first vertebroplasty was done in France, that too at the C2 level for the hemangioma thing by a radiologist actually. But then it got popularized because it is minimally invasive and with immediate results in most of the patients. The objective is to provide pain relief, to provide stability, to increase height. They are questionable objectives because most of the time even the height increases, it doesn't stay for long. It again comes back, but it provides wonderful pain relief. Mechanism of pain relief is mechanical theory by the stabilization of the fracture, because as we all know that all the fractures bones are painful by internally. So once the vertebra is fractured, it is severely painful, and most of the time it is osteoporotic. The cement goes inside, gives the mechanical stability and provides pain relief. There is also one thermal theory, because this cement causes a lot of exothermic reaction. So it burns down the neovascular or neurogenic components of the fractured vertebra. Indications are, most common is osteoporotic. It's actually a social issue in India. It's a silent killer, especially for our half of the population, that is the female population, very much prone and unaware of the osteoporosis. And then there is neoplastic fractures, that is because of the metastasis of different organs. Again, radiotherapy is the main line treatment, but if radiotherapy is not effective or not possible for any reason, vertebroplasty, cementoplasty provides excellent pain relief. And then it is not the measure to decrease the pain, it is actually the treatment. So it's better to call it a treatment of bone metastasis rather than a pain relief measure of the bone metastasis. Then tumor infiltration and hemangioma. So pre-procedure imaging is the must thing to make the diagnosis and to check the feasibility whether it can be done. Start with radiographs where you see a fractured vertebra, but to see the age of fracture you need a MRI. MRI is the golden standard if it is possible in that patient, because it gives you the idea of the chronicity of the fracture, whether it has been healed or it is likely to be healed with the conservative care or not. So here you can see that L2 vertebra is fractured, slightly fractured upper end plate. This is a wedge fracture. Another here you can see it's a majorly collapse. Another MRI, as I told you, because at MRI you see many things. You see the fractured vertebra, you see the posterior displacement of the fractured vertebra. So this is something ominous. If it is there, it is not your case. You have to refer the patient for the open fixation and decompression. But here you can see that these are your cases, some of them. So MRI is a must thing. Another picture of MRI. If MRI is contraindicated, go for CT. Or even in some patients, when you are having doubts about the integrity of posterior wall of vertebra, you need a CT scan to see whether this, because bones are much more visible on the CT scan than the soft tissue. So CT is sometimes a must to have a posterior wall idea. What are the contraindication? The absolute contraindication is posterior cortical defect. This is absolute contraindication because, well, you will fill this bone with the cement. Cement is likely to come into this canal, and that is catastrophic. That will going to compress the neural structure and may land into the paraplegia. The anesthesia which is required, we all do all the cases in the monitored anesthesia care and local anesthesia only. Rarely, almost never we use general anesthesia, but our surgical colleagues, they do vertebroplasty, kyphoplasty in general anesthesia also. This is the assembly. Here you can see that this is Jamshidi needle or bone biopsy needle. Different sizes are available. This is the cement, and this is a cement mixer assembly. So cement is made up of polymer and monomer, that is PMMA, most commonly used. Now there is another cement, hydroxyapatite also. And there is opacifying agents, which is very important, that is barium sulfate is the most commonly used. And it is higher concentration in the cements used for the vertebroplasty than it is for the normal cements used for the orthopedic or neurosurgical procedures. Here the concentration is 20% weight by volume, which is a must thing for us pain and spine physicians, because liquid cement otherwise is not very much visible on the X-ray CM fluoroscope if it is having less than that quantity. So I have already discussed this. These are contraindications. You can see that there is metastasis, but it is extending into the canal, not our case. Relative contraindications, when there is spinal canal stenosis or there is vertebra is too much collapsed so that it becomes technically difficult. So in the initial periods, these are the relative contraindications. But once you get exposed and expert, you can do whatever level, and how much compressed doesn't make any difference. Positioning. Prone is the position with the patient. Patient has to lie down with the slender cushions under chest and one under the pelvis to increase the lumbar lordosis, because we want to open up the fractured vertebra like this. So we increase the lumbar lordosis while the positioning. Approaches, most common is transpedicular, where we use the pedicle to reach the vertebra here. And another approach is parapedicular, where we directly go into the vertebra. Transpedicular is most commonly used. Parapedicular is more useful at the thoracic levels. End point of needle placement is anterior 1/3 and middle 1/3 junction, because this is the place where venous plexus is less. Secondly, end point of the cement filling is when cement starts coming into the posterior part of body, then you stop. Amount of cement, many people used to think that we have to completely fill the vertebra in initial duration, but now it has been proven completely that even a small amount of cement, suppose 1 or 2 ml cement, is good enough for the very good pain relief. So amount of cement doesn't make difference between the amount of pain relief you achieve. And same is the thing with the number of vertebrae to be treated. There are few patients where multiple collapses are there. Not all of them are active. You need to ascertain that on the MRI, but you can still go for the 2, 3, 4 levels. So this is slight leak. So important thing to remember here is that there is no problem in this parapedicular anterior to the vertebral leak. Only thing which is prohibited and not desired, that when the cement leaks in the canal, spinal canal. So you can see that the angle can also improve by the restoration of height. This angle here, it has been decreased. So there is good restoration of height also in some patient, and many levels can be done and different types. Now this small video. Oh, sorry. कैसे चलेगा भाई? Today we are going to do a vertebroplasty of L3 level. You can see there is an anterior vase compression of the L3 vertebra, and patient is having point tenderness here. Please focus over here. If we see the axial picture, we can see that this compression is more on the left side and pedicles are intact. So we are going to use the transpedicular route to do the vertebroplasty of this patient. Now the patient is in the prone position with increased lordosis. That means there is one pillow below the pelvis of patient and one pillow below the chest of patient. So the abdomen is hanging and increasing the lordosis of lumbar spine. That will help us to reach the target point. This procedure is being done under the Siam fluoroscope. So now you can see that this is the AP picture, and we are going to target L3 vertebra because that is compressed. That vertebra is looking collapsed. This is the 11 gauge bone biopsy needle which we are going to reach the transpedicular route into the L3 vertebra, which is collapsed one. This is our plunger to push the cement in. These are the 1 ml disposable and sterile syringes which I will use to inject the liquid bone cement, that is PMMA. This is local, and now we will start the intervention. You can see that pedicle is open on the left side. We are going to enter the left side. Yes, we will bring the pedicle inside the vertebral body. So we will inject the pedicle. Yes, we will inject here the skin, then the subcutaneous tissue, and use a spinal needle to reach the pedicle. Because pedicle is painful, this is a painful procedure. Patient is under conscious sedation only, completely awake and aware. ठीक है आप? ठीक है? गर्दन एक तरफ करके रखें आराम से. ऐसे कर लो. Okay. So we are going to inject. Yes. So we have reached the pedicle. I will give a liberal amount of local anesthetic to anesthetize the pedicle so that this procedure become painless for the patient. And then I will inject the local anesthetic on the tract. Yes. So now I will make a stab incision through the help of 11 gauge blade. That will help me to put my needle. So you can see that my bone biopsy needle is in the gun barrel view. Tip is slightly going toward the lateral side. I will correct it. Yes. I will make it perfect gun barrel before I go inside. Yes. And slightly on the upper side. These minor corrections are very important to reach the intended place. Now I will go inside, fix my cannula. This is AP picture. Yes. So we are going in the right direction. We will check it in the lateral picture, lateral view, the depth. This medial pedicular line which you can see on this AP picture should not breach before we cross the pedicle in the lateral view. That is very important step during the vertebroplasty. Yes. So we have just entered the pedicle. That is far away from the vertebral body. We will go ahead in the AP picture. So I will go in the same direction because pedicle medial wall is quite far away.
The important point here and this point is this is the medial pedicular wall and it must not be breached in the AP picture before you clear the canal in the lateral picture. So if lateral, again I will check the lateral picture. You can see that medial pedicular line is still away. Yes, I have almost crossed midway, again AP.
And every time you advance your needle, it is in the AP
Slightly
picture.
correct my direction towards the cephalad side. Yes, lateral. Again lateral. So these AP and lateral pictures both are very important for the safe conduct of this procedure, which is percutaneous vertebroplasty. Yes, so we have just crossed the canal, just 2 mm away from the posterior vertebral body, and this is the space I have still with me in the AP picture. AP. Yes, so I can safely go ahead and check in the AP picture. Yes, still there is place from the medial pedicular line. I will again check in the lateral, and we will go up to the border of medial 1/3 and anterior 1/3 of the vertebra. Shoot. 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 Yes. 1 more millimeter, and then I am done. Shoot. Yes.
But I hope that I could clear my message that medial pedicular wall is while doing this intervention. And it must not be breached in the AP picture before you clear the spinal canal in the lateral picture. So whole game is between the AP lateral till you reach the vertebral body. Once you have reached the vertebral body, you can directly go into the lateral picture up to the junction of anterior 1/3 and middle 1/3 of the vertebral body. And then you start mixing your cement. You take it in a consistency of toothpaste. Use a 1 ml syringe or cement injecting devices otherwise available to fill the cement in the live lateral fluoroscopy. So there are two things important. One, you advance the needle in AP picture till you clear the spinal canal in the lateral picture to reach the vertebral body. Second important point, you inject the cement only in the live lateral fluoroscopy. ये दो चीज़ें कभी भूलनी नहीं है अपने को. There are complications which may happen minor most of the time and sometime major also, like the cement reaction, or it can be like canal displacement of the cement. So this is also a complication where a slight amount of cement has leaked into the disc, but it is unconsequential. So minor complication, there are cement leak at different places, but not in the canal. A small lung embolism can also be there because cement may go into the venous plexus. Major complication is rare, fortunately, if you are taking care while doing the injection of cement. So here this is a complication which should not happen. Where cement has been leaked into the canal, but amount is slow. The someone who was doing it, he stopped in that time because of using the live lateral fluoroscopy. God is great. भगवान बचा लेता है अगर छोटा बहुत ज़्यादा सीमेंट लीक हुआ है तो, but it should not be too much. This is again slight leak. If you are using scopy, then you stop. This is another picture. Here some flakes of cement in the lung field, again non-consequential, but these are bad. This is bad. It must not happen, because then the only answer is immediate exploration and open surgery, which may not happen in time, and patient may land into the paraplegia and cauda-equina syndrome. So what happens when we don't intervene? This is our own patient, 23rd April. You can see fracture vertebra here, and just in 2 months time, you can see the condition of fracture. So please, whenever you get a patient, do treat it aggressively, because it is not going to heal by itself in most of the patient, because bones are already osteoporotic. Any level, as I said, can be done. These are extreme vertebroplasty, so they respond beautifully. And patient, it's one of the very satisfying, gratifying intervention in whole pain medicine, where patient comes on bed on a stretcher and walks after half an hour of the cementing. So all these patients, same with the metastatic, you can do multiple level, and wonderful relief and treatment of the bone metastasis is possible. No level is taboo if you can keep on having experiences. D9, D11. Kyphoplasty is also very good, same thing. And this is one patient, I am not going into detail. Another patient with subacute fracture. So efficacy, it is effective in up to 90% patients. Dramatic pain relief after the cementoplasty. And same is the scene with the neoplastic compression fractures. So assumptions, there are few assumptions that it is contraindicated in moderate to severe retropulsion, but now with the kyphoplasty thing, we can manage them if there is no bladder bowel symptoms. If greater height loss is there, it was considered contraindicated, not anymore. So take home message is, this is a procedure, vertebroplasty or cementoplasty, for the improved quality of life, which is very important. In India, the age of living is continuously increasing. So are these patient number is also increasing. We need to take care of our elderly population, and appropriate therapy should be started for the osteoporosis also. Once you fix the fracture, your job is not over. You have to take care of that. There should not be another fracture. You need to treat osteoporosis aggressively. So thank you very much for having me here, and sorry for the technical glitches.
Thank you, Dr. Anurag, for wonderful presentation. Any questions? Thank you, Dr. Anurag.
Thank you.
I request Dr. Jayesh Rathod to present a memento to
Nikal do na?
Dr. Anurag. Jayesh. I invite Dr. Gagandeep sir to present to moderate the next session, that is on freelance session. Thank you, Dr. Anurag. Thank you, Jayesh.
Yeah. Good afternoon, everyone. Am I audible? Oh. Yeah. Hello. Good afternoon, everyone. I'm really thankful to the organizers for having a freelancer session. As a matter of fact, I do not know about the Class A cities, but I practice in Class B city, and say around 90 to 95% of the anesthetists are working single-handedly. And they have their own set of problems. And as a matter of fact, the task group always is aware of the fact, and they always have a freelancer session where we try to discuss the daily things that we come across. I remember the time when I started practice around 25 years back, and graduating from AIMS, then having a stint in UK, then I went to my friend and said, I want to practice in my hometown. And what do I need? I practice in Meerut, and at that time, things were very primitive. So he told me, I mean, you just have to manage. You have all the things with you so that you can give anesthesia roadside. The next day I went to Chavdi Bazaar and bought all the red rubber tubes, the laryngoscope sets, the airways and everything, and I thought I have everything in my bag so that I can give anesthesia roadside. So that was the state of affairs. Today we have some interesting topics, and for those of you who will not know what is a jugaad is an improvised vehicle where a diesel generator set or a scooter set is set up on a trolley which is used to ferry agricultural equipment or people even. So jugaad is a makeshift vehicle which comes into play. As a freelancer, when we do not have access to everything, we devise ways to give better and safe anesthesia practices to do. So paucity is the mother of invention. And I invite Dr. Vikram Alsi to come and tell us about some of this jugaad things that can come in handy in our practice.
Good morning. It is indeed a pleasure to get to talk here, especially after speakers like Sood Madam, who is probably at the pinnacle of what we can achieve as anesthetist. And after listening to all these speakers, I am going to talk on jugaad. Exactly not jugaad, I'll like to call it innovations. Jugaad, everyone is aware of the word, but what I am doing or the innovations that I have seen my colleagues do over the years. Why we need jugaad? That is the first thing. That is the main reason is everyone doesn't have the facility to travel maybe first class or VIP as this. And the facilities that the guidelines that we follow, they are all developed by American Society of Anesthesiologists. Recently, few years back, we had some guidelines by Indian Society of Anesthesiologists also. But all these guidelines are developed by people who are working either in metro cities or they are heading big institutes. So what they advise is actually not always possible for us. And what we get is usually not available, means they have no idea what they are talking about. We have shortage of infrastructures. No nursing home likes to invest in anesthesia. For them it is a expense and not a money generating. For smaller hospitals, the change in some corporate hospitals can be seen. We don't get dedicated person or anesthesia help. Yesterday Harjinder ma'am said she had someone to give the drugs for her. Like, it's a very big privilege for people like us. We have to take our own drugs and give, because that experienced technician made that mistake, and if we allow that, every day we will be making a lot of mistakes. So we don't have that help. Even if there is some catastrophe and we need help, where we are placed, we won't have time to get help. So we are on our own. This is the kind of a institute, one of the institutes that I work along with Dr. Nilesh Mathankar. But I do less than 1% of my cases in place like this. A good workstation with gas monitor, fiber optic bronchoscope, everything. Where I work is this. A Boyle's machine, madam has shown that as a museum kind of a thing. We are still using it, ma'am. And the only thing that this machine does is mix oxygen and nitrous at the set rate. Like, I want to give 2 liters, it will give 2 liters. There is no chain link or oxygen safety and a lot of other things are there in this. There is nothing in that. It's just me and this machine. And if you see the monitor also, this is just taken few days back. After this talk was planned, this is this. One patient I was doing, I just thought I'll take this picture. It just shows pulse ox and NIBP. It's a good company monitor, Philips, but even ECG is not there. This is the kind of places I work. I started my practice in 2003, and at that time I used to go with one of the laparoscopic surgeon. We used to sit in his car, all his stuff was there, and we used to put an oxygen cylinder along with that. And he'll have his monitor, the laparoscopy instrument, the whole camera, light source, and huge thing. And we'll go to different places and operate there. I used to carry an oxygen cylinder, pulse ox and veins, because I was not sure what we'll get there. And just on the vein circuit and oxygen cylinder, attach it directly to the cylinder and do the case. It sounds very dangerous right now, but I have done that. The only way to maintain anesthesia was give ketamine, and it used to be not a very happy anesthesia for me also and for the patient also. So then I started carrying formalin, a small box with epidural to his syringe. And I used to give a single shot epidural before giving this, because everywhere it was written we should not give spinal for laparoscopies. This is way back 2003-4. And with epidural and GL, a GARA or whatever, which is now promoted very much, I had better patients. But the epidural was too cumbersome to do in that with no help available. So we shifted to spinal plus intubation. And eventually we realized that we get very good patient, we can do on spontaneous with the intubated patient. And then we just started doing plain spinal, very high spinal laparoscopy. That is how I started doing it. Only spinal, the patients were very comfortable, never had any problems. Rest of the presentation. Okay, right, it's okay. I think by this few blank slides were introduced. Yeah, so patient never had any problem. The patients were very comfortable. But anesthesia society, the people, my friends, they were not very supportive. They would say you are doing is unethical. Can you just remove this "got it" from the live captions? Yeah. It's unethical, illegal, even you may get in trouble, immoral. Some also used to ask that whether you will do it for your own family. After 20 years till now, I have never needed one for my close family, but my friends and surgeons whom I work with and their relatives, we have done a lot of laparoscopic surgeries under spinal. The method and this what I used to do 15 or 18 years back and today is way different. We are even going for segmental today. We already had this yesterday, and also what I am saying is evidence. Though I do more than 1,000 cases since last more than 14 years every year, because of a private practitioners I don't have the data or this to present, but there are a lot of enthusiastic private practitioners who have come up with a lot of data. This is just if you Google laparoscopy under spinal, the evidence is there today. If asked whether I would do the same thing today, in today's world, my answer would be no. Today it's not safe to do what I did maybe 15 years back. It's not safe for the patient, it's not safe for the anesthetist. If anything bad had happened, then I would have been screwed. Sorry for the word. So what is the first thing that I suggest when you go to such a thing? I think is you convert that boils which you saw to something like a workstation. So for us, a workstation is if you get a ventilator, my hands become free when I give a GA. That's all. All it has to do is replace the bag. So I don't have to do this for 2 hours, 3 hours or whatever. If I have my hands free, I can take care of the patient better. This is a simple ventilator which I use. This is attached to the Bain circuit, a Newman ventilator. This is also developed by one of our private anesthetists from Ahmednagar, Dr. Gaisas. All you have to do is replace the bag and attach to the ventilator. I didn't have the test lung at that setup, so I just attached a reservoir bag to get this. So if you can see, here you can see the numerical, that is the pressure, and the blue light that shows the volume. So from that you can guess how much pressure it's going at. You can get the PIP, peak airway pressure and the volume. Though it's not very accurate, but you can manage your cases. There is no shortcut. You should be able to identify just from that when there is obstruction or leak or whatever, only from two values that you get. So all the jugaads or the things I am mentioning, these are not shortcuts. It is application of more of the knowledge with limited data. Like from a pulse waveform, if it's not irregular, you know it's not correct. But only whether it is an ectopic or it is because of cold or movement. So we have to be more vigilant. We cannot be relaxed because we don't have ECG. Nowadays, most of the centers I go to, we have a multipara with ECG. Sorry, ETCO2 is not there. So still we are guessing how to go about ETCO2 with just heart rate, blood pressure, and most of the cases I don't use relaxants. So the spontaneous breaths and this, I'll come to the relaxant part later. Another thing which is talked about a lot in conferences is awareness, depth of anesthesia awareness and BIS. I don't know, but I have never seen a BIS monitor, only in pictures or in conferences, and in practice I have never seen one. So how do we manage that awareness? Because it's a real problem. I have seen a lot of patients, luckily not mine but others, who complain of awareness and they are not very happy with it. So what we do is maintain the hemodynamics with anesthetics. Induce hypotension, bradykinesia only with this. Do not use too much relaxant. Do not use NTG or beta blockers to control your this. All the drugs we use is propofol, Dexket, and magnesium paracetamol tramadol combination. That really helps. Propofol infusion along with dexmedetomidine is another very good this to keep the patient under good hemodynamics and the patient is not aware. So it's a simple things like this that help you work around the low resources that we have. TAS has been very good in helping us. We conduct nerve blocks for the masses where without a USG machine, how to do most of the blocks, educate on multimodal analgesia, the mixture which I said, tramadol, paracetamol and magnesium in one this, that is very good for us along with GARA, gamma, all this helps. Nerve blocks is another thing, and my suggestion to all who do not have the expertise available, means the facilities of ultrasound available, that you master at least one block for each part. A very simple interscalene block or axillary, supraclavicular, whichever. So that will take care of majority of your analgesia and anesthesia part if you have to do a prolonged surgery also. So the requirement of anesthetics is reduced. I follow a very keep it simple approach. Spinal, epidural or unilateral for lower limb, interscalene block or an axillary, and for abdominal laparoscopies and thoracoscopies, either go for spinal or paravertebral block, tab blocks. Very simple blocks available very easily on YouTube, or Hetal has all the videos, you can follow that. Another important thing you can do is LMA. LMAs are not very expensive because we can reuse them. So the LMAs, they help you, like you can prolong, means how do I say, your anesthesia up to 4 hours also under LMA, not an issue, and in these setups is really helpful to you. There is no need for me to talk on LMAs, everyone is aware and using it, but we use up to 50, 60, 70 times iGel, and it really helps you with the cost. And last thing I would like to mention, it's only for private practitioners with limited resources, Bollywood anesthesia. This is not seen anywhere or any reference except in Bollywood movies and sometimes in Tollywood movies also. And I'll tell you, you see a movie, he's undergoing a major neurosurgery and he will have only mask or even cardiac surgery or whatever that will come. कि वो सिर्फ भगवान बचा सकता है kind of a surgery, and all he has is a mask. So this is that patient. I have done a hand debridement. So I am giving him oxygen along with isoflurane. This was one of the better setups I work, but just to show that this can be done, because I didn't have time to this and the patients. So this is what we do. Just through the oxygen mask, give isoflurane. It's wastage of isoflurane. Environmentally, it damages a lot, but it saves you. It gives you free hands. You don't have to keep on repeatedly giving bolus of the anesthetic drugs, and half an hour, 45 minutes procedure can be easily done. Sometimes I also use nitrous along with this, and it's very easy. You just have to switch off the nitrous if there is fall in saturation, and the anesthesia is maintained. Disclosures none. There is nothing here to disclose. Thank you. Thank you.
Yeah, thank you, Dr. Vikram, for an insight into the little jugards that you are doing. And it's another problem is sometimes when you have a problematic case, it is a dilemma whether to call, give a prior call or give a on-spot call. If you land up in a problem, then you have to give a call. I request Dr. Nilesh to let us make us wiser as to when to call for help.
Thank you, sir. Just at the outset, I should congratulate Hital Bhai for designing such a very practical-oriented scientific program. But in the process, what he did to me, he has given me a topic on which there is no literature available. So, I see a lot of consultants sitting over here, and there is some literature available for trainees when the trainees should call for help, but there is very little available for consultants. And if I talk about consultant anesthetist, it is nothing available on the literature. And pertaining to this topic, when should I get? It's impossible to get anything. So my talk will be a very practical one, and I'll try to do justice to the topic and also to your valuable time. I have just one disclaimer. Some images I borrowed from internet. So when do we call for help? When we get difficult anatomy, airways, difficult airways are the most common cause for call for help, or unfamiliar pathology. So any pathology which we are not familiar with, we are not doing that kind of cases. We are doing mostly ASA1, ASA2 type cases, and of course the cardiac one is the most common there, 32%, life-threatening emergencies, and VIP patients. Now VIP is a little relative term which might vary from center to center, place to place. And how this helps? It helps us taking decisions in a rapidly changing dynamic scenario. It can be a technical help to us. And if we debrief our emergency management, self-debriefing, then we'll find that often we get fixated on some issues, right? So it is very helpful to get a different set of eyes, to give us a different perspective on the scenario. Of course, moral and emotional support is there. Sometimes it is a learning opportunity for us if we call for help. And of course, if it is a VIP case, there is somebody to share the load, and it kind of provides us a political cover. But the ultimate aim of seeking help is getting peace of mind. So now we know that help actually helps, The question remains, when should we call for help? Before induction or after induction? So Vimohan, I don't see him, but in his talk he was repeatedly asking, if you are smart enough, if you are smart enough. I wanted to tell him that we are the anesthetist, we are the smartest people, and we have devised a very simple solution to most of the life's when problem, and that solution is very simple. Is it elective or emergency? But, it is in a simplified world. But in real world, it does not happen. In real world, what happens? We are always in a dilemma to call or not to call for help before induction. In emergency, it's not a problem, right? Before induction, I am always in dilemma. Why? Because I have a reputation. I want to keep my reputation as an independent, decisive, confident, and a very dedicated anesthetist. But if I call for help, my reputation is damaged. And most of us know that reputation is business for us. Competition. What happens if I call for help? My client will see, oh, he's calling for help. Why shouldn't I call this person directly? And third most important thing is money. I have to share my money, right? Nobody is going to come to help me for free. But it's okay. There will be certain situations where I will need help. And how to take the decision, when should I get help before induction? That is the most problematic scenario. Now, I would like to ask a question. How many of you will call for help before induction on gut feeling? Okay, so quite a lot of number, yeah? But I want to tell you about gut feeling. What is gut feeling? See, gut feeling is actually a culmination of your experiences and the emotions attached with the past experiences, right? So, gut feeling becomes more reliable only with experience, right? So what we need is a very objective method to take this decision. So I will propose a decision-making triangle and would like you guys to move from gut feeling to pure logic. And this triangle would be, you should ask 3 questions to you. Are you experienced enough to deal with such cases? Do you have proper equipments to conduct that case safely? And what kind of setup you are working in? If you don't have any 2 of these, you should directly call for help. If you have at least 2 of these, you can rely on your gut feeling. And if you have all the 3, you are a blessed one. So let's test this hypothesis on various scenarios, and these scenarios are real life scenarios where either I called for help or I was called for help. So a very occasional pediatric anesthetist was called for craniotomy of a 4 kg, 4-month-old baby with an intraventricular tumor of 3 centimeters. Pediatric equipments were available, but the adult setup was there. So the hospital did not have any pediatrician or neonatologist. So should this guy call for help before induction or after induction? So he doesn't have experience. Setup is adult. He should directly go for help before induction. There is no doubt about it. In the second scenario, you can see a day after delivering a talk on a difficult airway, called for an arthroscopic, this happened to me, called for arthroscopic shoulder repair in a nursing home. And as we often do in freelance practice, you do a PSC on table, and I suddenly realized there was severe ankylosing spondylitis. There was no movement at all. And he has a fixed cervical spine. I did not have any equipments with me at that time. So I straight away called for help before induction because I had experience, but no equipment and no setup. Now, let's move to the third scenario. A 21-year-old male posted for lab quali in a very well-equipped super specialty center. He is son of very prominent person in the government. Now, this scenario we often get. Now, I am experienced. I have a good setup, and I do have all the equipment for conducting any case. Now, what should I do? Of course, trust your gut. There is no doubt about it. You do want some kind of a political cover at some point of time in your life. Now, things become very simple in taking a decision after induction. It's life-threatening emergency. That is the only. So what is life-threatening emergency? You need to recognize that a rapidly worsening of patient's clinical condition, it is half of the definition. The complete definition is which an equally rapid therapeutic intervention must match. You need to match that rapidly worsening patient, you must match the response. So, you need to recognize the condition early and anticipate that it can be life-threatening and immediately call for help. We know all the guidelines which are suggesting call for help first. So what are the common scenario for post-induction call for help? Unanticipated difficult airways, these are the most common ones. Cardiac arrest inside the OT, local anesthetic systemic toxicity, anaphylaxis, massive hemorrhage, and venous air embolism. These are the scenarios where except for last, I had called for help for, I think, 4 of these. So, this is to conclude, call for help provides the best possible patient outcomes, emotional support, political cover, and learning opportunities. Decision-making triangle may provide an objective method to assess the need to call for help before induction, and after induction is very simple. Thank you.
Thank you. Thank you, Dr. Nilesh, for being brief and being very precise.
Thank you.
The next, I'll invite Dr. Sushil Garg for a very, very important topic. As freelancers, sometimes, and most of the times, we are in a dilemma whether to accept or whether to say no. In fact, the art of saying no, it is actually an art. Even after 30 years of my marriage, I am still devising ways to say no to my wife so that she doesn't get offended. So let us, let Dr. Sushil Garg enrich us on this art of saying no.
Good afternoon, everybody. Thank you, Tascon, for giving me a time to speak on this topic, and thank you for choosing me a president for the next session. I am working in a private hospital at present. I am owning the hospital. Now, initially I was working as a freelance, and I used to be paid by the surgeons. Now I am working in a hospital and I am paying the surgeons now. My topic is the art of saying no. How I became a freelancer. I passed out from the Army Hospital, Delhi Kent. After passing out, I went to Ma'am Sood. Okay, ma'am, I want to work with you. So she said, okay, you come, we have a place in a cardiac anesthesia. So I was feeling very much, I want to learn basic things, because in Army Hospital we have all the gadgets and we worked on the extremes. We never had seen a boils apparatus there. Then I went back, gave a second thought, and went to a MCD hospital to learn the basics. I wanted to see a boils apparatus. I wanted to work on Goldman vaporizer. We never had seen a Goldman vaporizer in our hospital that time. No, it's a big thing. Who are we? We are the anesthetists. This is the picture of 2014. This was our first conference which we held here. We work in government hospitals, we work in corporate hospitals, nursing homes, diagnostic centers, ICUs, patient transport, and in some of the disaster management team also. Our mission is always do no harm. Our society was formed in 2014. That time we had planned of this and targeted is safe anesthesia, safe surgery and safe patient. How do we achieve this? We keep a focus on patient safety. Everything will come in your mind. Whatever your procedure you're doing, if you think, say, it's safe for the patient, you can go ahead. In patient safety, there are analysis, hygiene, sanitization. There are many guidelines, safety protocols and quality management like ISO, NABH, JCIs. But what about the nursing homes? We don't have any protocols there. There are self-made protocols. If your gut feeling says it's okay, you can go ahead. Otherwise, you don't have any standards in the nursing homes. You will find these pictures everywhere, but nothing is followed there. We as a freelance, we work in corporate hospitals. We are employed basically, but the freelance term is used just for our salary purposes to save on taxes. There we work under the seniors, we are paid less, we have a job insecurities, we have more working hours, and all the decisions are made by the seniors. In a small nursing homes, there are compromised setups. Lack of safety devices, low payments, low backups, lack of backups, no protocols, untrained manpower. We don't have any well-trained manpower as we see in the corporate hospitals. In the peripheral hospitals, these are still far away from the smaller towns. We don't have any backups, don't have a trained staff. Those places are very high risk because they have no standards, no backup to reach that very fast. Even though we can go for a call for a help, but it will take another 30 minutes. It is a disaster. We face many challenges, like high risk places. We have no backup support, leg pulling from the seniors. That senior will do the case. He says, "Hey, yaar, ye case mein mana kar diya isne. Why I can do it?" So seniors will pull your leg. If we have a failed spinal, your senior will pull up in that center so that he can come back in that center. Other challenge is the anesthesia technicians. We have been teaching the technicians for safety of the patients, but with time they have started learning to give a spinal. Now I have seen number of OTs where the OTs are run by the technicians. We are sitting outside having a coffee, and in smaller places like mine place, I have one anesthetist is taking 5 technicians. They are running the 5 OTs simultaneously, and the other anesthetists are not getting a chance because technicians are paid very less and the job is done with them. We see the corporate OTs. There is a corporate anesthesia team, but in the peripheral OTs, we don't have these setups. Everything is compromised. The Boyle's apparatus still we see that, which ma'am has shown in her slides. This is still a luxury. You have someone helping you give a spinal. This is Dr. Gagan, which he was explaining. It's a jugaad. This is the picture of that vehicle. It is a jugaad. In Punjab, we call it as a jugaad. Otherwise, other people say it is an innovation. It's one and the same thing. This is just to give oxygen in the OT or anywhere in the ICUs. Once I had gone to a OT. One surgeon said that there was a Boyle's apparatus, and that Boyle's apparatus was having a big leak in the oxygen part. So I said, "Sir, Goldman he says, put ether in that Goldman and it will work." I said, "But the ether won't be pushed because the oxygen is leaking before that only." He says, "Put ether in this bottle. Take nasal, put and give oxygen." This was the jugaad which he was improvising. But this is how you have to say no, because somewhere you have to make a limit. Other example was, there was a full stomach during my PG days. There was a 4 years child, and my pediatric surgeon said, "Agar do the PAC, I want to do the surgery." That was a 4 to 5 p.m. in the evening. I said, "No, sir, he's a full stomach, we can't do." My guide, Colonel K.K. Upadhyay that time, he called me, he said, Garg, you can't refuse anesthesia. You say, yes sir, you will take up the case. Just the risk varies. His full stomach, let him document he has an emergency, he has to do this case. Not because it's 4 p.m. you refuse and he says, I want to take. Just increase the risk. Let him say it is an emergency. So this is one of the way to tackle the situations. Now it is indirectly the surgeon will say no. There was another case of thyrotoxicosis now where I was working in a nursing home. Patient had to undergo a hysterectomy, which was under spinal. Patient was having anxiety, flushing and tachycardia. I examined the patient. I said, sir, this patient is not fit for surgery. He says, no. After seeing the documents, I saw she is a case of thyrotoxicosis and not well prepared. I refused. The surgeon said, यार तूने तो spinal लगाना है, thyroid तो ऊपर है, manage हो जाएगा. This is how we are treated. Another example was of kyphoscoliosis, fracture neck femur. I was very new to practice as a freelance. I got a first call in that hospital. I was very happy. Once I saw the patient, he was 4-foot patient and with kyphoscoliotic chest, he was coughing badly. I had my own stethoscope, I auscultated and says, no sir, he needs to be worked up. Worked up? What worked up? You give spinal, spinal won't be effective. Maybe I require a GA, and that OT was the same OT who had an ether bottle there. I had to say no because I couldn't take the risk. I said, sir, I have to prepare this case. I said no. I thought next time some senior anesthetist will go and do that case. Unfortunately, that after 5 days, he called me again, okay, now it is prepared. Finally, I had to undergo under TIVA. I did that case. It went successful. So there is a government setup. Patient was hypertensive, 160/100 BP. The anesthetist refused the case. My wife works in a government setup. She called me and she said, will you do this case? I said, I'll do the case. You bring to my hospital. So why is that anesthetist refusing? Because of the setups. She doesn't have a backup over there. I have all the backups. So it doesn't mean if someone is doing, if I am making that case fit, I have a backup. I have 10 things to think. And that person is refusing it doesn't mean she or he is unqualified or she can't do. She can be better than me, but because of the poor setup, she has refused. We are well versed with the physiology, metabolism and the risk factors. We as anesthetists, we know much more than the surgeons have. How to say no? We should be having a very much clear vision. We should know the implications of saying yes. Because if doing that case, high risk case in a peripheral setup, we should know. We should tell the surgeons, these are the risks. If he is ready to take, he will say yes because he is getting money. We will be paid poorly, but document everything. Dr. Tyagi, what yesterday told us, we should document. And while document, you should sign the papers with date and time, which is more important. Because time also helps us. Realizing saying no is okay. It is better to say no, rather than we become more justifying ourselves, we will take up the case. We should know the workplace, where we are working, where we are taking the case. I am working in Punjab, Bathinda. One OT is fit for the case, same case I can't do in the other OT because there is no backup. Any case, we should keep the things very simple. We should assess the patient. We should also know the surgeon. One surgeon does the case in half an hour, other surgeon does in 2 hours. He says, though I am a slow surgeon, I will do very neatly. It doesn't mean he is doing neatly. He is giving a more exposure time. Maybe there is a lot of bleeding in that. So we should know the surgeon also seeing the patient. Like the diagnostic center said, correlate clinically. We should also correlate the situation. It's not only if patient is for hysterectomy and he will do very fast. No. We have to see how is the surgeon, how is the setup, what are the condition of the patients. Is the patient worked up? No. Peripheral patients are not worked up. While saying no, we should be very humble. And if we find anything deficiency in our checklist, we should have our own protocols. We have a standard protocols for everything, but to our situations, we should also have some protocols. One day, Dr. Vineet said, I used to refuse. If the OT doesn't have a atropine, this will make available. No, he used to walk out. Thing is, what I used to do is I used to carry 2 ampoules of atropine, a vial of mifentrine in my pocket, so that I don't miss a case. I can't walk out of the OT because I'm a freelancer. I won't be paid then. Everything I used to keep in my bag. Sometimes the surgeon says, if you come to know this case, the surgeon is very slow and will take a lot of time. How to refuse is, you yourself become busy. I never say no. I say, sir, I am busy, it will take some time, an hour, half an hour time. The surgeon used to call to other person. Postpone the case if you need. How I did is kyphospholytic patient, I had to postpone. Unfortunately, I got the case, but after that I got that center also. You explain the condition, you explain the risks, not only the surgeon, document it, explain to the patient, to the relatives also. Sometimes surgeons refuse it, but you have to accept it. In our life, there are hours of boredom, minutes of thrill, and seconds of horror. So in the end, if you say no, no means no. You have to accept it. Thank you.
Thank you, Dr. Sushil. I have an announcement to make from Dr. Heetal. After conclusion of this session, we are going to have a group photograph, because immediately after lunch, few people want to leave. I now invite Dr. Meenal Chauhan to share one of the hair-raising experience that she underwent and how she was able to tide over the crisis. We, as freelancers, we all have these bone-chilling experiences, and once we get into those, this could be iatrogenic problem or this could be patient-related problem. And once you are into this, you bribe your God. If I do that, I have to say, God, I'll not party for 7 days. Get me out of this. So, over to Dr. Meenal Chauhan now.
A very good afternoon, everybody. At the offset, a big congratulations to the organizers for an excellent academic feast which we've had over this weekend. And thank you for inviting me to speak on a topic which I think all of us must have encountered at least once, if not many times. So I'm presently working in Metro Hospital and Heart Center. So greetings from Haridwar. This is the river Ganges, of course. So, unsinister, la catastrophe. These are the words which come to my mind when I think about that fateful day. They say you meet your fate on the road you take to avoid it. And this is exactly what happens when there's a medical emergency which lands you into trouble. And then everything from your technical skills to non-technical skills, everything comes into picture. So let me take you through a case of mine. A 22-year-old female was posted for right femur implant removal. So had done her PSC, everything was normal with her, given her a subarachnoid block with 2.8 ml of 0.5% heavy bupivacaine, level T8 achieved, and I always document the time. It was 1:20 p.m. 1 hour into the surgery and she started shivering. So I gave her a few blankets. But then she was shivering more, so I gave her about 50 milligrams of tramadol added to the drip, which is what we normally do. There was about 200 ml of RL remaining. And within 5 minutes, I saw an erythematous rash, which was there on the forearm. Patient was complaining of tightness of chest, and there was she was like, I'm not feeling well. There was impending doom on her face. There was tachycardia, 180 pulse, unrecordable BP. So I had come across anaphylaxis, for all we know. The team was alerted immediately. Multitasking was started at all levels. I luckily had a good team. So they started giving mefentermin. I was on the head end. I was managing her with 100% oxygen. Because she was under subarachnoid block, I had to immediately give her that. People were giving her everything but adrenaline. Avil, Hydrocort, everything was started giving. And then there was somebody else, I told them to prepare an adrenaline injection. So then adrenaline 100 mics, I gave her IV. Around this time when all this was happening, I saw that her BP had started picking up a bit. So I induced her with 100 milligrams of propofol and scoline because she was almost unconscious. I tried to intubate her with a number 7 endotracheal tube, but what I found was a swollen uvula and arytenoid, so my first attempt failed. There was a lot of erythema there. She started coming out, so I had to again repeat scoline with atropine, and I this time used a bougie with a number 6.5 ETT, and I could intubate her. Maintained her on vecuronium, isoflurane, oxygen and air, and by this time about a liter of NS had already been given to her. Auscultated the chest and found her to have bilateral wheeze, but luckily the saturations had never fallen below 95%. Gave her IV derifylin, immediately added to the drip, and started her on Duolin and Buticot nebulizations while she was being ventilated. Now all of this, I had all of this available because I was working in a good setup. I am working in a good setup. Another 100 milligrams of Hydrocort was also repeated. So what really saved us and the patient? I think it was hawk's eye attention to every fine detail which was going on in the operation theatre. I was not on my phone. I was alert while I was giving drugs, and an excellent team basically who actually heard whatever I was saying and following my instructions impeccably. A patient surgeon who did not panic, who let me do my work patiently, and availability of all the important drugs and equipments. And of course, when you attend seminars, lectures like these, and you come across such scenarios, you talk about it in the open forum, discussion with your colleagues, groups, all of this helps when a sudden adversity comes your way. So what happened next basically? Surgeon asked to continue the surgery because I had intubated her. Her vitals were somewhat normal. Chest auscultated, there was only slight decrease in wheeze, though the tachycardia, hypotension had begun settling. So I gave her another 300 mics of IM adrenaline. Nebulizations were now switched over from Duolin to ipratropium. Chest became clear after about 2 hours. Now what was my next plan of action? I wanted to extubate the patient on table actually, but the only hindrance was the airway edema. So I did a direct laryngoscopy. I checked the cords, and it was already 3 hours, I think, into giving adrenaline and anaphylaxis having taken place. I found them to be normal, not really as normal as probably they must have been before the anaphylaxis, but at least the erythema and the swelling had decreased. I extubated the patient once. She was breathing spontaneously, good tone, good hemodynamics, so I decided to extubate. Shifted to the ICU, but continuous nebs were going on with hydrocortisone cover. Next day only, that means after 24 hours only, I shifted her to the wards. The auxiliary work which went along with this was, I inquired about sending the serum tryptase levels in my institute, and there was no such availability. It was a Saturday, and they said that the earliest sample they could send was on Monday. So I could not send the sample. The patient party was immediately counseled after the patient was stabilized. I told them about the allergic potential of this drug, and then is where the husband started telling me about all the allergies she has. When I done my PAC, I had got no history of the allergy from the husband or the wife. And then they told me that she was allergic to diclofenac as well. So a proper documentation was done with a good scolding given to them. So what exactly is anaphylaxis? The international consensus of anaphylaxis defines it as a severe systemic hypersensitivity reaction that is very rapid in onset, characterized by life-threatening airway, breathing, circulatory problems, and you may or may not have skin and mucosal changes. The pathophysiology is IgE mediated mostly when there is small amounts of antigen. Then the mast cells, they degranulate, releasing histamine, leukotrienes, prostaglandins, proteases. So this is where tryptase becomes important. But when you have a huge amount of antigen, the IgG antibodies are also into picture, and that is when the neutrophils and the monocytes, they also start releasing platelet aggregating factor. So the histamine plays a central role in anaphylaxis. There is something called as non-allergic anaphylaxis also. These are non-immunological reactions, and the here it is direct vasoactive mediator release or direct activation of the complement system. Sometimes in patients where basal serum tryptase is already high or there is mastocytosis, anaphylaxis may be particularly very severe. The epidemiology. So there is a non-uniform ICD-10 coding actually of anaphylaxis. No studies in India, no database in India, everything has been done abroad. There is a NAP6 trial, which I'll be talking about soon, and all the trials together have come to the conclusion that, that there is about 1% chance of all of them landing in emergency in anaphylaxis, 7 to 50 patients per 1 lakh in a year, and mortality is really high, as you can say, nearly 10%. In children, food is the major factor, but in adults, it is venoms, and here we are talking about operation theatre, so it is drugs. So what is NAP6 basically? It is the largest ever prospective study which was done on anesthesia and surgery for anaphylaxis. 100% of the NHS hospitals participated, and every single life-threatening anaphylaxis case was taken. There were about 3 million records which were reviewed over a period of 1 year. So this is basically in gist, what did they find out? They found out that the incidence of peri-op anaphylaxis is 1 in 10,000. I don't think it's so less, I think it's much more. Antibiotics were the most common trigger, and out of that, teicoplanin, actually, you know, a lot of us are giving that, a lot of us use some other alternatives to penicillin allergies, but they found that teicoplanin has 17-fold more likely to cause anaphylaxis. The second most common was muscle relaxants, and in that, scoline, succinylcholine happened to have maximum effect. The low blood pressure was the most important symptom, and 3/4 of these patients required ICU admission, and 15% of them required CPR actually. So quite a lot of anaphylaxis. Now anaphylaxis is not just simple, okay? It is divided into various grades, and depending on the severity of the symptoms. Grade 1 starts with a little itch and flush, pruritus, erythema, there's angioedema, swelling of lips. This is something which is very common, and we see it very commonly happening around us, which responds to Avil and hydrocortisone. But the problem starts when we get into grade 2, 3, and 4. Grade 2 is when the abdomen gets involved with nausea. There is some little rhinorrhea, maybe a little hoarseness of voice when the patient is under spinal anesthesia. I was lucky that my patient was under spinal anesthesia and could tell me, of course, along with the signs which I could observe. And the cardiovascular system, there is tachycardia in grade 2, not of that extent, hypotension, arrhythmias, but again, they are manageable. Grade 3 is where the problem starts actually. When the patient gets into laryngeal edema, bronchospasm, severe hypotension, shock. And grade 4 is cardiac arrest or the respiratory arrest. So I think my patient was in grade 3 already, would have progressed to grade 4. So the symptoms, they begin really acutely, very quick progression. It can deteriorate within minutes, killing the patient. The reaction, though, can come to a spontaneous standstill at any stage and can also regress spontaneously, but in spite of adequate therapy. There may be only circulatory reactions present without preceding any cutaneous or respiratory signs. Sometimes there is also a protracted course, that means about after 6 to 24 hours also, the same signs and symptoms can reappear. And then there are also delayed anaphylactic reactions which have been documented. Now this slide I've put specifically because a lot of times, you know, patients, they complain of these kind of symptoms when we give them certain drugs. There's itching happening in palms, there is metallic taste, they are having headache. Young children, they will present with restlessness or withdrawal behavior. Sometimes in upper respiratory tract also, they will say there's, you know, itching happening in the tongue, the palate, everything. And of course, I spoke about muffled voice, hoarseness, dysphagia, and also an inspiratory stridor. So these are the initial prodromal symptoms which start to happen. And then we come to the sense of impending doom which was there in my patient, because she just kept saying something is happening to me, I will die, something is happening to me. Now because of vasodilatation and increase in vascular permeability, there is a lot of fluid loss which happens in the extravascular spaces, and that is what leads to hemoconcentration, hypovolemia, a lot of hypotension and tachycardia. All of it is because of the vasodilatation. The diagnosis happens by measuring serum tryptase levels, which are done at 1, 2, and 24 hours. If possible, you should do a basal serum tryptase also. Now, serum tryptase, it begins to rise within 30 minutes, and it has a T-half of 2 hours, 120 minutes. So what is the medical management? Immediately you have to call for help. Because there are so many things happening simultaneously, administration of drugs, maybe intubation, or at least securing the airway. You might need some extra help here and there, maybe to diagnose what is happening. There can be few other DDs also. So you must call people for help. Patient, whichever position they are in when the surgery is taking place, please stop the surgery, ask them to be made supine. Crystalloids are to be given, not colloids. 0.9% NaCl, best is a balanced electrolyte solution. Fluids are given at a rate of 20 ml per kg body weight. 20 ml to 50 ml per kg body weight can be given. So fast gush of fluids is what is required. So IV line, a large bore cannula, and if you don't have a large bore, please take one or at least take 2 cannulas. The flow, the FiO2 has to be above 0.8. And that is very important. Then that is your decision. You want to intubate the patient, you want to just put an LMA, you want to just give a CPAP. That's all depending on the situation. Corticosteroids, they prevent biphasic reactions and they have membrane stabilizing effect, but they do not treat airway obstruction or circulatory collapse. And normally 200 milligrams is the dose for adults, children, depending on the age. H1, H2 antihistamines, they treat only cutaneous and upper respiratory infections, symptoms, and the dose is 10 milligrams. Again, they do not treat the airways. But the most important drug is adrenaline. So they have the alpha-1 adrenergic action, vasoconstriction happens, diminishing airway edema, diminishing hypotension, thereby shock. The beta-1 receptors, positive chronotropy and positive inotropy. The beta-2 adrenergic receptors, dilating the airways, and most importantly, blocking further release of histamine. So immediately when this happens, you must give IM injection in a dose of 0.3 to 0.5 milligrams adrenaline, which can be given to the outer upper thigh. That is the therapy of choice, first choice. And the ampule which we get, it is 1:1000. 1 ml of adrenaline. That particular ampule, only half of it you can give. In case there is no response, the injection can be repeated every 5 to 10 minutes. Now, subcutaneous injection used to be given, but no longer that is good because it delays the onset of action and erratic absorption. So these are the doses. Now, IV dose 50 to 100 micrograms can be given. Now, this is 1:10,000 dilution. So you take that 1 ml and you dilute it into 10, and 0.5 to 1 ml of that can be given. Various guidelines are ranging from 50 to 200 mics. In children, you have to make it further diluted, so it becomes 1 lakh dilution, and you give 1 mic per kg. Now, there are also infusion rates, because you're all working in the ICU, we know about the infusion rates also. So 3 milligrams can be put in 50 ml saline, and we can start the infusion at 3 ml per hour. These are 3 ampules. 3 milligrams are the 3 ampules. Inhalation of adrenaline is effective in case there is laryngeal edema and bronchospasm, and for that you can put 2 ampules of adrenaline and 3 ml of NS, and you can give it through a nebulizer. Here I did not do that. I got a result with salbutamol, and though I gave Duolin, later I read that Duolin was of no use. So salbutamol doses have also been given to you here. So why is there resistance to treatment sometimes? Because they are already on beta blockers, maybe. They are on ACE inhibitors, which basically reduces bradykinin clearance, or maybe they are on NSAIDs, which are known to cause severe anaphylactic reactions. So refractory anaphylaxis is treated with epinephrine infusion, which I already told you. Certain other vasopressors can be given, and glucagon. Glucagon is given 1 to 5 milligrams IV over 5 minutes. Rapid administration should not be done because it can cause vomiting. So these are the various other vasoactive amines, dopamine, NORAD, vasopressin, we all know about it. We are using it regularly, and all the tables and charts are available to us. But while all this is going on, continuous non-invasive monitoring, pulse oximetry, urine output has to be in place. If your patient has not been catheterized, please make sure that you immediately ask the surgeon to do so. Follow-up is important. Refer to immunologist or an allergy specialist.
Kindly try to finish fast.
Done. And you have to report to the pharmacovigilance center. Now here in our country, we don't have a proper reporting mechanism. So this is what I did. I actually made an incident reporting team in my hospital and set up the at least basal tryptase levels can be given. So vigilance, calm mind, alertness, and a bit of luck. I think a lot of luck is required, and we are able to sail through very difficult situations also, but I think most importantly, it's the team. It is my team which helped me and which made me go further, and thank you so much.
Dr. Meenal, why are you so sure about anaphylaxis in this particular case? I'm not aware of anaphylaxis to tramadol. Pardon my ignorance. I would like Dr. Sood's words on that. But why didn't diagnosis of a pulmonary embolism come to your mind? All this symptomatology that you have mentioned could have been present because in a pulmonary embolism also, because implant removal from a long bone femur fracture. So how did you rule out a pulmonary embolism?
Yeah, I did think about fat embolism or a pulmonary embolism, but the symptoms were so evident, sir. There were rashes immediately the moment I gave her tramadol. The rimming was taking place, I mean, and it was implant removal, sir. So all that was already, the TOCO and everything was taking place since last half an hour. Nothing happened at that time. The moment I gave her tramadol, that very moment, all these symptoms appeared to me. Immediately, firstly, it is my thing. I wanted to send serum tryptase levels, it was not available. That was one thing. Second thing, after giving her adrenaline, her symptoms immediately started improving. The moment I gave her adrenaline and the nebulizations, her symptoms started improving immediately. I feel that if it was pulmonary embolism or a rare embolism or something, I don't think with adrenaline immediately
Did you ever give a kind of a CPR, partial CPR
No,
to her when she...
I did not require that because she responded immediately to 100 mics of IV adrenaline.
I would request Dr. Sood to kindly comment.
Of course, you managed the case very well. And although these incidences of anaphylaxis are rare, but when they happen, they happen. So I think rightly so, because the procedure had not started, I think.
It had started, ma'am, 1 hour into the procedure.
1 hour into the procedure. So unless reaming was done, only then you would think of an embolism.
Yeah.
But I think immediately if you started something and you had the symptoms, I think I would also think of an anaphylaxis first.
Thank you, sir. Thank you.
Thank you.
Now I invite all faculties on the stage. I invite Dr. Atanu to present a memento to Gagandeep sir.
I'm going to love it because he's my senior.
I him. Now I invite Dr. Shishir to present a memento to Vikram. I invite Dr. Saurabh to present a memento to Dr. Nilesh Mathankar. I Dr. Chintan Vyas to present memento to Sushil sir. Dr. Sumit Khatri to present a memento to Before we go for lunch, we will take a group photograph. So please.